Welcome back. I apologize for the interruption. This is now part 3, third video and final video of the pain management in the laboring client, chapter 16. Now that we've discussed the many ways in which we can manage pain in the laboring client, let's focus on the nursing care. And again, we left off discussing epidurals, and we talked about that IV bolus up to 2 liters, minimum of 500 to 1,000 before initiation. Other things that you want to pay close attention to is the woman's platelet count. If anyone has a platelet count less than 150,000, they would not be a candidate for epidural placement due to the risk of bleeding. We've talked about that positioning, the sitting or side lying, and what your role is as a nurse. We certainly talked about blood pressure monitoring. Immediate post-procedure, we would be doing every 5 minutes, and then hourly when mom is receiving epidural management. Bladder distension. So the effect of the epidural on the bladder would require us to assess bladder status throughout the labor process. There was a time in practice where a Foley and indwelling would be placed immediately after an epidural. That is no longer recommended in the literature. Evidence-based practice tells us that that increases the risk of a catheter-associated UTI. Therefore, we'll monitor the bladder status, and we will straight catheterize the mother as needed through the labor. We'll monitor her level of pain, of course, because we want to make sure that we're managing the pain appropriately, keeping in mind that epidurals have highly reliable pain management statistics that go along with it. However, there are some women who can experience what we call a window, or an area that for reasons that it just didn't tap into that section neurologically of the nervous system, that she may experience some pain, and we would report that to our healthcare team. We want to make sure that we're turning this mom. Remember, she now has lost sensation of her lower limbs, so she cannot turn herself in bed. So we have to make sure that we're turning her. And we do that every hour in labor. I know that you learned in the general population for reduction of risk for things like DVTs and skin care that it's every 2. In the laboring mother, it's every hour, because that promotes and facilitates the labor process. Always safety is a concern because of decreased sensation and mobility of the lower limbs. We would not get her out of bed till she has complete return of sensation, can lift both legs off the bed and feel touch there, and we would be with her when we get her up to go to the bathroom, let's say post-delivery on her first 2 attempts. If she does have the catheter insertion site on her back, which she will have one, and it's usually taped with a transparent occlusive dressing, we would assess that routinely, keep it clean, keep it dry in the labor process, and report anything that looks suspicious to the the anesthesiologist covering. And as far as return of sensation, most women will have full return of sensation within 4 hours after the infusion to the epidural catheter has stopped, which will typically happen, again, depending on the labor process and progress, depending on the parity status of the mother, could happen as early as in the pushing stage or as late as delivery of the placenta. And then we would be looking for those signs that she can lift her legs and feel us touching her within 4 hours. So these are some of the contraindications to epidural placement. If the woman has any hypotension, whether it be in the labor process or a history of hypotension, be given the side effects of epidural, it would not be a good choice for pain management in labor. If she has a history of coagulopathy disorders, so blood clotting disorders, or some blood dyscrasias, may exempt her from this method of pain management, or if she's on any kind of anticoagulation like heparin, Lovenox, or warfarin. She's likely not on warfarin. And we obviously would discontinue the epidural if it looked like there was any kind of infection or redness at the site of insertion for the prolonged labor process. Increased intracranial pressure, absolutely no spinal access for this client. And if we can't get her into that position, which seems like, wow, maybe that woman would really need an epidural, but if she can't maintain the position and actually be still while that procedure is being performed, then it may not be able to happen for her. And that is it. Thank you.